This clinical illustration shows two presentations of a condition known as the ulnar claw hand. On the left, we see a severe deformity characterized by hyperextended knuckles and tightly curled ring and pinky fingers. On the right, the clawing is noticeably milder. Both of these deformities are caused by damage to the ulnar nerve. In clinical anatomy, this is often called the musician's nerve because it supplies the exact motor units required for the highly independent, fine-tuned finger movements used to play complex instruments. Because of its anatomical routing, this nerve is highly vulnerable to physical trauma at two primary locations, higher up the arm near the elbow and further down the limb at the wrist. This diagram illustrates a logical contradiction known as the ulnar paradox. Basic mechanics suggest that severing a cable closer to its power source should cause more widespread failure. But with the ulnar nerve, a proximal injury at the elbow yields a mild physical deformity, while a distal injury further down at the wrist triggers a severe structural collapse. Resolving this mechanical impossibility requires us to abandon the top-line clinical presentation and completely reverse engineer the nerve's anatomical routing, step by step, from the spinal cord to the fingertips. This reference text establishes our starting point. The ulnar nerve originates from the medial cord of the brachial plexus, pulling its specific nerve fibers from the C8 and T1 spinal roots. It is a mixed nerve. This means it acts as a two-way highway, carrying motor commands outward from the spine to the muscles and transmitting sensory data back from the skin to the brain. To understand how this system fails, we have to map the physical architecture of its branches as it travels down the limb. In peripheral neuroanatomy, the geographical layout of a nerve dictates everything. Where a nerve drops its branches directly determines the downstream clinical consequences of a physical injury. The nerve begins its descent from the axilla, or armpit, running straight down the medial side of the arm, parallel to the axillary and brachial arteries. This schematic shows that as the nerve travels through the axilla and arm, it gives off 0 branches. At mid-arm, it pierces the intramuscular septum, moving to the posterior compartment. It then passes behind the medial epicondyle into the ulnar groove. This groove is superficial and highly exposed. It is the exact location you strike when you hit your funny bone, and it serves as the prime location for proximal ulnar nerve injuries. Because the nerve acts strictly as a closed conduit through the upper arm, an injury at the elbow acts like a master switch. It risks cutting off the signal to every single motor and sensory target located further down the arm. Moving past the elbow, the nerve threads the gap between the two heads of the flexor carpi ulnaris muscle to enter the forearm. In the forearm section of our schematic, the nerve deploys its first muscular branches. It supplies the flexor carpi ulnaris and drops a crucial connection to the medial half of the flexor digitorum profundus, or FDP. This close-up demonstrates the mechanical role of the medial FDP. When commanded, it forcefully flexes the distal phalanges, the very tips, of the ring and little fingers. Shortly after, about 5 centimeters above the wrist, the nerve releases its dorsal cutaneous branch to provide sensory coverage to the back of the hand. The critical takeaway here is mechanical location. The physical pulling power required to curl the tips of the medial fingers originates from a muscle belly located high up in the forearm, not in the hand itself. The main trunk of the nerve continues its descent toward the wrist, passing superficial to the flexor retinaculum. It enters the hand through a narrow anatomical tunnel called Guyon's Canal. This tight passage constitutes the second major vulnerability site, setting the stage for distal lesions. Inside the hand, the schematic shows the nerve splitting into a sensory superficial branch and an active deep motor branch. This deep branch contains dense motor distribution, powering the interossei muscles, adductor pollicis, deep head of the flexor pollicis brevis, and medial 2 lumbricals. This diagram isolates the lumbricals. They perform a highly specific counterbalancing action. They flex the MCP joints, bending the main knuckles, while simultaneously extending the IP joints, keeping the finger segments straight. This extensive, intricate network of deep terminal branching is what actually provides the fine motor control necessary to earn the title of the musician's nerve. But this density comes with a mechanical flaw. Because the vast majority of fine motor control branches off after the nerve enters the hand, the entire system can be crippled by a single pinch point at the wrist. We can now establish the mechanical baseline of an ulnar claw deformity. When the medial lumbricals are paralyzed, their counterbalancing force is removed. This allows opposing muscles to yank the main knuckles into severe hyperextension, while the finger joints fold inward into flexion. This 3D schematic simulates a distal injury at the wrist. The lesion paralyzes the lumbricals inside the hand, initiating the claw deformity. But because the injury is at the wrist, the signal to the FDP was already delivered upstream. That connection remains perfectly intact. This active, functional FDP continues to forcefully contract, pulling the distal fingertips into deep, unregulated flexion. This active pulling is exactly what makes the visible claw deformity so severe. Now, we simulate a proximal injury at the elbow. The signal is blocked higher up. The distal lumbricals in the hand are still paralyzed, but crucially, the medial FDP in the forearm is now also paralyzed. This resolves the paradox. Without the active pulling force of the FDP yanking the fingertips inward, the fingers lie relatively straight. An injury closer to the spine shuts down more muscles, resulting in a less severe visible claw. Regardless of the severity of the claw, all complete ulnar nerve lesions share a universal set of clinical deficits. Patients experience a complete loss of finger abduction and adduction. Without the interosseous muscles, the physical ability to fan the fingers apart or squeeze them together is completely gone. They will also show a positive Frohman sign. The paralysis of the adductor allicis forces the patient to heavily compensate with other thumb muscles when trying to pinch or grip an object. This medical illustration maps the nerve's distinct sensory profile. Lesions result in numbness strictly over the medial 1.5 fingers, extending down the medial aspects of both the palm and the back of the hand. The complexity of the musician's nerve lies in its density. A single bundle of axons descending from the neck manages to orchestrate the most independent, finely tuned mechanical actions the human body can perform. True anatomical understanding isn't about memorizing lists of symptoms. It requires recognizing that spatial architecture dictates mechanical function. By mapping the specific pathway of the ulnar nerve, the counterintuitive logic behind its clinical failures